Welcome to my YouTube channel. Today we are going to talk about management of infantile hypertrophic pyloric stenosis. Kindly make sure you subscribe. It will cost you absolutely nothing. So the management, pyloric stenosis is not a surgical emergency. However, it's a medical emergency and you need to correct that medical emergency. And why is it a medical emergency? Because we have lost a lot of ions, so we have a lot of electrolytes. The kidney is not helping us to resuscitate or to go back to normal. So initial resuscitation is very paramount, and what we do an gastric tube to drain off the stomach content and prevent recurrent vomiting, and you keep on the NG tube free of drainage with hourly aspiration. In addition to that, you replace losses for ml that you can give 0.9 sodium chloride and 10 millimoles of potassium chloride. You can also give intravenous fluid. Remember what we said, that what are we going to lose? We are going to lose water, we are going to lose potassium, we are going to lose chloride and hydrogen. So intravenous fluids, you give the fluid 0.9 of sodium chloride in addition to 5% of dextrose. This is for glucose. And then afterwards you confirm the urine output. Blood glucose concentration should be monitored. The blood glucose concentration should be monitored. So most infants come to surgery within 12 hours, but long-standing vomiting needs to be carefully monitored and prepared and stabilized over 3 to 5 days so that the surgery can be performed later. Once the infant blood tests are normal. So you just don't go, as you said before, this is not a surgical emergency. You have to weigh this patient. Are we metabolically stable? Was what we brought in, because this patient will come with hypokalemia, hypokalemia, dehydrated, meaning we have less water and less sodium. So we have to go back to normal, that we have to balance our electrolytes to be normal. So we can also, after you have stabilized the patient in terms of medically, then you can do surgery, and the choice of surgery is Ramsted myectomy. So the surgery, this slide has a lot of content, but we just go through one by one. So the surgery, you can either do laparotomy or laparoscopy approach, depending on your skill or the place that you are in. Do you in a high resource setting? The surgery that we are going to do is Ramsted myectomy, and the principles of this surgery: the pylorus is held longitudinally, is seen here, and a longitudinal neuromuscular incision is usually made, as seen here, and then the incision can be made by a blade, diathermy, or a laparoscopic blade. And then the pre-pyloric veins of Mayo. This is just a diagram showing us the venous supply. I wanted us to see the pre-pyloric vein of Mayo so that I don't give you another assignment of coin and ring. You can just check it here. Marks the pre-duodenal junction. So this is the pre-duodenal junction and distal end of the pylomyectomy. So when you are doing the pylomyectomy, you are not going to go distal to this, you are going to go proximal to this. So if you're going to make your incision using the other or blade or laparoscopic blade, then you're going to start here moving proximally. Understood? And the proximal incision is extended to the palpable end of hypertrophic muscle onto the stomach. So I hope that is understood. So you start your incision here, and if the hypertrophic muscle ends here, then there is where you're going to end your incision. And a blunt spreader, this is one of it, a blunt spreader or a pyloric spreader or a pair of mosquito forceps or a back of the scalpel blade or a laparoscopic spreader, then squeeze the muscle until the mucosa is seen bulging. So the adequacy of the myectomy, check the adequacy of the myectomy, and also check the perforation can be done by inserting hair into the stomach, the NG tube, and demonstrating passage into the duodenum, or by the movement of the two leaflets independently. This is also called shoe shine maneuver. So you choose what. I think I will choose the first one, by inserting hair into the stomach with the NG tube and demonstrating passage of the hair. If perforation is identified, then it's oversewn by a 5-0 absorbable suture and the omental patch sutured over the perforation. So in addition to that, you can also do conservative management. And conservative management of infantile hypertrophic pyloric stenosis is possible, but is usually associated with higher morbidity and mortality than surgical management. So if it is therefore rarely used, and it is used for few cases that may be required, include patients deemed for hostile surgical abdomen. So for example, a patient comes in and they had previous giant exothalmos, where we have an open abdomen. Necrositizing enterocolitis is an infection, and patient with severe comorbid that makes the surgery and anesthesia dangerous. So the conservative management consists of prolonged NG tube drainage, replacement of the ongoing losses, that is electrolyte losses, prevention of parental nutrition, obvious, because if pylorus is stenosis, then our nutrition is very crucial in this pyloric stenosis. Entire pharmacological treatment is associated with pyloric stenosis. Because it is a hypertrophy and if you have a smaller lumen, then you can provide drugs to relax that pylorus. And atropine is thought to relax the pylorus and decrease the time of resolution of symptoms in infantile hypertrophic pyloric stenosis. Parental or peripheral nutrition is very important in this patient. Parenteral nutrition, we have two types of nutrition: enteral nutrition and parenteral nutrition. So enteral nutrition is where you use the GI to feed this child. Parenteral nutrition is where you just inject the nutrients into a vein, which could be central or peripheral. So in this case, you're going to use the peripheral nutrition. So as per natural history, conservation management may be needed up to 6 weeks to allow resolution of symptoms. So post-op care, the NG tube, remove the NG tube after completion of surgery, unless obviously we have breach of the mucosa, and then you continue with intravenous fluids, that is normal saline and dextrose, and then restoration of oral feed after 4 to 6 hours post-op if there is no complication. Then start 25% of normal feed 3 hourly and increase as tolerated, and then reduce IV fluid as obvious as you take the intake, so that you cannot overload the patient. And then discharge once tolerated 2 full feeds, usually 150 ml per kg per day, and no any other concern. However, minor vomiting may be expected 1 week post-op. So complications, we have several complications. In the first one, we actually touched on it, in this duodenal perforation. So if non-duodenal perforation, you continue with NG tube, and add 48 hours of IV antibiotics, and you delay oral feeding for at least 48 hours. If you did incomplete myotomy, that you did not actually separate or did not give the space to the muscles, then you go in for a relook or a reoperation. 2% usually need a relook. Wound infection, this is when you have infection. Persistent post-op vomiting, this is usually defined by prolonged vomiting for greater than 7 days, and is usually caused by too rapid adjustment of the post-op feeding or residual pyrotonic edema. So persistent and frequent daily vomiting in post-op period may require an upper GI contrast study. So in addition to that, the last one is pyloric stenosis may persist, and that may need a redo. Thank you.